Hey Mo,
Hey, Ricky.
doctor is in.
Yes, the doctors are in today.
I
Happy
know.
Wusa Wellness Wednesday. I love that dress.
Thank you. This is my Women's History Month dress, right?
Oh my gosh, that's
So
incredible.
I'll put the name of the designer in the chat because I think it was probably like $40. They're really like reasonable, but she shows everybody. So it's a great thing.
Is your face on there?
My face isn't. I'm not that famous, Mo.
Well, I think it should be.
I think
And
we
I
should
think
make our own dress for me and you. All right.
we can do a TNBC, the many faces of TNBC dress.
Yeah, we can.
Welcome everybody to the Doctor is in. We are so excited to have you with us today. And today's show is really going to, I think, stretch and test your health literacy. So everybody who's been watching this show for the last year and a half knows that we talk a lot about understanding your diagnosis, understanding some of the science, and you don't have to understand everything, but be able to have a conversation with your doctor about what your diagnosis is and be able to tell somebody else what it is and maybe even serve then as an advocate or a buddy or a bestie to others. So this conversation today is going to take what you sort of kind of understand and it's going to
Whoa.
in the best ways. In the best ways, though. So we're going to talk about triple negative breast cancer. Many of you know what it is. If you don't, we want you to put a question mark in the chat that says, I don't know what TNBC is. Just put a question mark in the chat for us. And we have a really exciting guest who's on the cutting edge of some amazing, amazing research. Ricky, how did you find our guest today?
You know what? I was going to ask Dr. Goetz that too. I don't remember. How did we meet? I'm always digging to find researchers, but did you find me or did I find you, Dr. Goetz? I can't remember.
Ricky, I found you because
you did. Okay.
I wanted to find out, who was really the person that's really reaching out to patients in this area, and boy, it's been a great find. I'll say that.
You're a great find. So it's TNBC month, and we're trying to do something, all month long to talk about advances in science, and we are all about advancing the science. So we have our big movement that we started a month ago called When We Trial, because we know that we don't want Black women to die anymore. We don't want anybody to die of breast cancer, but we need science to happen 24/7. And thank you so much for doing this work for us. And so, I'm going to say something about you from your bio, but then you need to tell people who you are. And Tammy, then you need to introduce yourself. But these guys are from the Mayo Clinic, and I'm sure you guys have heard of the Mayo Clinic. It's like a major center of health. So Dr. Goetz's title is, right, the Professor of Oncology and Pharmacology, Mayo Clinic College of Medicine and Science. And you've been recognized by a lot of people that I can't even pronounce their name, but it's all great. But you basically are the co-chair of the Mayo Breast Cancer Disease Group and co-leader of the Women's Cancer Program and the Mayo Clinic Cancer Center and director of Mayo Breast Cancer SPORE. So, wow, you had a lot of titles in your title. So it just means that you're doing amazing work and you're trying to advance breast cancer science for all of us. So, you guys should introduce yourselves, and then Tammy, you talk and introduce yourself, please. And we're going to talk about some stuff that's like way over my pay grade, but try to break it down so everybody understands it, because an educated patient makes for a better doctor and saves lives. And these guys are saving lives. So thank you for coming.
Well, Ricky, thanks it's a pleasure to be here to meet you and Monique, Dr. Gary. And so I would say that what you need to know me at the bottom line is I'm a doctor that takes care of patients with breast cancer. That's really at the heart of who I am. What I do is patient centric, and my goal is I'm a medical oncologist. So that means that I take care of patients with medicines. Obviously, Dr. Gary is a surgeon. She takes care of patients by doing these critical operations, and we all work together in teams, and that's one of the things that's great. I do, in addition to taking care of patients, the other thing I do is I spend a lot of my time trying to develop new drugs and new treatments for patients who have a diagnosis of breast cancer. And where this is really important, of course, is for patients where their cancer has spread and they've run out of standard therapy options. And so that's certainly a passion of mine, and it's what I do in terms of leading our breast cancer research group. our SPORE, it stands for Specialized Program of Research Excellence, is really designed to take discoveries that are made in the laboratory and to move them into the clinic to really to reduce morbidity, suffering, mortality from breast cancer. And that's what we do.
That's incredible. May I ask you a little more about your why? Why breast cancer? Is there any personal connection or a story, a patient story, anything that sticks out to you that kind of drives us home? Because we love to tell the stories and tell patients that their stories and their narratives have power.
Well, it's a really good question. And, it's a little bit complex, partly because of the fact that when I was going through my training, I had, it's a little bit about how you meet, and sometimes it's about your mentors. And mentors are people that obviously you look up to and say, wow, I'd like to be like them. And I just happened to be, around mentors who were doing some incredible work in breast cancer. And that's really how I came into the field.
Wow. Hi, Tammy. How you doing?
Wow.
Good.
Would you tell us a little bit about yourself as well?
Sure. So I'm a senior program coordinator. I work with Dr. Goetz, and I provide administrative support to the program. So managing grants and budgets, but I also provide support with the studies. And I work very closely with Dr. Goetz and other people on the TNBC study. And thank you for having me today.
Very, very cool. How long have you guys been together?
Well, our SPORE has been in inception, since about 2005. Tammy and I have been working together just really this last year, although Tammy's been working in other areas in research here at Mayo Clinic and working in translational research. And so we sort of were able to identify her and bring her into the SPORE, and we're really happy that she's working in this area of translational research and just doing a wonderful job to help. It takes a team, and that's the thing I'll say. It takes a team to try to bring these discoveries into the patients and to ultimately improve the outcomes of our patients.
So what is translational research? What does that mean?
Great question. So, when we think of research, sometimes research sounds as something like, well, something you might do in a petri dish in some laboratory in some, windowless building in the middle of nowhere, and it's not very exciting. Well, in the case of cancer, translational research to us means that you're taking and you're working on something that directly applies to patients. And there are many types of translational research, but one type of translational research would be taking a discovery in the laboratory in terms of perhaps how some cancer cells might respond to a drug, using that information, then to move those drugs into patients. So, for example, one of the things that my laboratory does is to closely look and evaluate at how breast cancer cells that are resistant to some of the standard chemotherapies, what are some of the new drugs that we can use or develop, and so my laboratory studies these cancer models, cancer cells, if you will, and then uses that information to kind of prioritize new drugs that we can move into the clinic. And that's one form of translational research. Translation just means taking what you learn in the laboratory and applying it to patients.
That's fantastic. So that could be animal studies. It could be petri dishes and cell lines and other things as well, but stuff that impacts patients more immediately than, we just kind of keep studying those molecules at their very most basic components, right? I love this.
And making it work in our bodies, right?
That's it.
And I think one of the things that's really exciting is that, we've used many different drugs for many years. And these drugs, by the way, we wouldn't use them if they weren't effective. They are effective. But, for some patients, they work really well. And for some patients, they don't work as well. And so one part of translational research as well is trying to understand, why does a drug work in one woman, but it doesn't work in another patient? And we'd like, of course, we'd like to have a drug that works in everybody, but it actually doesn't work that way. We're complex, just like we have, we wear different dresses on a different day. So we have these complexities that and differences that really do affect how we respond and to these medications, and that's a very important part of our research.
We're seeing that so much for Black women. I mean, you know, and I went actually and dug like in history to look like what like how many Black women were in the clinical trials for TAC, right, for the standard of care for most breast cancers. I couldn't find any. And so I really, you know, we are really trying to dig into the science, because I do believe that Black breast cancer is different, and that we need either different dosing or different treatments, different drugs. And so all the science is so important. So help us understand why TNBC, triple negative breast cancer, is such a nasty thing. And like, what's so bad about it? And why do we need more help with it? Why do we need more drugs and better drugs?
Well, I'm going to just start with, just in general, when we think about cancer, I think one of our gut reactions when we think about cancer is that all cancer is bad at all times in all places, and I think that's not a bad reaction. I think, you know, certainly no one wants a diagnosis of cancer, but we also know, as we look around us, is that there are some patients that are diagnosed with cancer that do very well, and it never really becomes a problem for them. Perhaps they're treated with surgery and the cancer never comes back. And then we have some cancers that are just they're just more aggressive. And when it comes to breast cancer, if we go back all the way to perhaps even 100 years ago or more, what people started discovering was that people responded differently in different situations. And there was a surgeon years ago who actually found out that in young women, that if you remove their ovaries in the setting of a diagnosis of breast cancer, that some of the tumors regressed, and it was just remarkable. And this particular surgeon, Sir Beeston, actually made this observation, and then he tried it again on another woman and who had breast cancer, removed the ovaries. In this case, nothing happened. It's like, well, why did it cause the tumor to shrink in one situation, but in another patient it didn't? And that was probably one of the very first, potentially, observations about this very important receptor that's made up of, that we think about when triple negative breast cancer, and that's ER, or estrogen receptor. And so his observation was that if I get rid of estrogen, and the ovaries, of course, are the major source of estrogen in a young woman, if I get rid of that estrogen, the fuel for the fire, that potentially then can cause the tumor to regress. But what he was surprised was it didn't happen in that next patient. And as it turns out, there are a group of tumors in breast cancer that do not have the estrogen receptor. And so you can change estrogen all you want, but the tumors may not necessarily regress or do anything. So that was a really important observation. And of course, later it was discovered that there is this receptor called the estrogen receptor, and that it's expressed, meaning it's present on upwards of 3/4 or 70% of all breast cancers. But actually, in about 30% of patients, it's not there. We can't see it. And so that is a very important observation. And as it turns out, triple negative breast cancer has the absence of that receptor, the estrogen receptor. It also, by the way, has the absence of two other receptors. One of them is the progesterone receptor, and the other one is the HER2. And people say, well, why is triple negative breast cancer so nasty? Well, it just turns out that it, as we thought, as people started thinking about and describing breast cancer, the absence of the estrogen receptor is a problem because, well, I'm not able to actually manipulate or change estrogen. So if I'm not able to,
receptor mean? What does receptor mean?
okay, I'm going to step back. I like to think of it as this is just basic lock and key.
Okay.
So you've got a lock in your door. The lock is the estrogen receptor. The key is estrogen. And so estrogen comes into that lock and by turning it, you're actually able to open up the door and do something inside. And so the estrogen receptor being the lock, estrogen being the key, so we think of both of them together. So in the case of breast cancer, the estrogen receptor is there. Estrogen is out floating around, let's say somewhere in the bloodstream. And when it comes in and it turns the key within that lock, then something can happen. And that something that can happen might be the growth of the cancer. Now, there are many different receptors that we think about, many different locks, but the estrogen receptor, of course, is one of the very important ones.
I love that.
Another important.
Yeah, that's so great. Yeah.
So
I use the example of the Pennsylvania Turnpike. And I say we're looking for toll booths on the turnpike. I'm from Pennsylvania, so we're looking for the toll booths. And if we see that you have the toll booth, we know that you're using the toll or you're using the dollar. And estrogen is your dollar. That's your currency. And people who don't have those receptors are in the easy pass lane. They're not using dollars. So taking away their dollars with a treatment wouldn't be helpful. They're in an express lane, so to speak. And it's an oversimplification, but when I say that to patients, they kind of say, oh, okay, I see why this is important, because they get their path report in their portal and they're thinking, well, what's the the per, and the her, and how does this have anything to do with, with my cancer? I just want it gone. And I love your explanation, though, of the lock and the key, because it really does turn on, turn off, activate, increase growth. And, so our estrogen receptor, maybe I'm getting ahead of ourselves, alpha and beta, are they two different locks, or are they the same lock and maybe a top and a bottom lock or something?
Yeah, that's a great question. So first of all, estrogen receptor alpha was the one that was discovered first. It's the one that we think about most commonly. And when you think about triple negative breast cancer, we think about estrogen receptor alpha, and we think about the absence. It's not there. Estrogen receptor alpha is present on a different part of the chromosome. Now, remember, we all get, we inherit genes or changes from our mother and father. We get chromosomes from our mother and we get some from our father. And in this particular situation, the estrogen receptor alpha is actually present on chromosome 10. And then it was discovered perhaps about 30 years ago or so that there's another estrogen receptor, and it's estrogen receptor beta. So now we're really confusing things a little bit, because now we have one that's estrogen receptor alpha, and then the other one is estrogen receptor beta. And as it turns out, there's quite a bit of similarity between the two, but there's also quite a bit of differences as well. And so one of the things that we're studying right now is actually, why is one important in one setting, and why is it important in, let's say, in another setting? So as it turns out, estrogen receptor beta, when it's expressed, actually causes a tumor suppressive effect. And people always say, well, what do you mean by tumor suppressive effect? I call it like putting on the brakes. You want to stop the growth of the cancer. So you're putting on the brakes of that, let's say, the growth of a cancer cell. So expression, or having the estrogen receptor beta, is actually a good thing. Estrogen receptor alpha is a little bit different. It's a little bit like adding fuel for the fire. It's a little bit more of an accelerant, if you will. So we have two different receptors. One is alpha. That's the one we all know about. And that's the one we think about when we say triple negative breast cancer. It's lack of estrogen receptor alpha. And then we have this one that people haven't really studied very much, which is the estrogen receptor beta. And that's an area of research that's quite interesting right now, because as it turns out, as I mentioned, that particular receptor might actually help to slow down the growth of the cancer.
Wow. But we have both.
We have both. And actually, as it turns out, these receptors are not just present on cancer, they're actually present on normal tissues as well. It's just that in normal tissues, they don't necessarily always act aggressively. And so people always say to me, well, I'm taking the drug tamoxifen. and tamoxifen blocks the estrogen receptor. Unfortunately, if it was only blocking the estrogen receptor in the tumor, you wouldn't have side effects. And what are the side effects that you get when you block the estrogen receptor? Well, you get hot flashes.
Menopause stuff.
You can get side effects related, in the bones. You can get side effects, as it relates to sometimes some muscle aches. So estrogen receptors are actually present on a lot of tissues. What happens though in cancer is the cancer cells can sometimes use these receptors to help promote the growth. And one of the great breakthroughs, of course, in the area of cancer is the ability to use a drug like tamoxifen, which can actually block the growth promoting effects of, in this case, of the estrogen receptor. So a woman has a history of breast cancer that's estrogen positive, and she takes a drug tamoxifen for 5 years. And what that drug does is I like to think of it this way. It sort of removes the fuel from the fire. If you think of cancer cells being in the body, tiny seeds that are out there and they're waiting to germinate, when you take a drug like tamoxifen, you're preventing the rain. You're preventing those seeds from germinating. And that's, of course, very critical for women with a diagnosis of breast cancer. For men with prostate cancer, we use similar approaches to block the androgen receptor, which, of course, is that important receptor where we take the male hormone testosterone. It binds to the androgen receptor. So steroid receptors, estrogen receptor, these can be present on cancer cells, and cancer cells can use those receptors to grow. And when you use drugs to block that can really be helpful to prevent these cancer seeds, sometimes that we can't see, and keep them from germinating.
Let me pause and say here, if you're just joining us, we're having a really detailed conversation, and we haven't even gotten to the research yet. That's how deep and layered this is, but it's so exciting and important for us to talk about it this way. We are talking about hormone receptors. We're talking about triple negative breast cancer and some really exciting therapies that are emerging in a clinical trial right now that's looking at the use of estradiol or estrogen to treat triple negative breast cancer. So, like, on my Facebook, I put estrogen to treat TNBC. What?
Right.
And I think now we can have this conversation. So,
well, go back one thing though. I just want to make a point too that like I couldn't take tamoxifen. Like if you have TNBC, we don't have one of those 5-year drugs that block. Right. So
exactly right. And the reason, by the way, that we know that, and I'll just say this is a plug for research, is that years ago, there were clinical trials where people said, here's a woman with breast cancer, and we're concerned that the breast cancer could come back. And so they did these trials where they gave women tamoxifen. And one of the things that they found out was that tamoxifen kept the breast cancer from coming back, but only in those situations where the estrogen receptor was positive. So if you're estrogen receptor negative, tamoxifen did nothing. Now, there was a period of time where we didn't know that. And so we would just give every woman tamoxifen. And again, some people would respond and some people wouldn't respond. And we would scratch our heads and we would say, well, why didn't she get benefit from tamoxifen? Well, now we know, of course, is that the estrogen receptor is very critical. Tamoxifen does not work when the estrogen receptor alpha is when it's not there. And this is a form of translational research we were just talking about earlier.
Absolutely. And do tumors have some combination, or I'll say heterogeneity, or some alpha and some beta in different proportions? Can a tumor have both?
So really good question. The answer is yes. And as it turns out, when we think about estrogen receptor beta, which is the second one, as I mentioned before, this is a receptor that seems to put on the brakes a little bit on the cancer growth. And so what we know in general, as we've looked at tumors that have estrogen receptor beta, is that the tumors grow slower. They don't grow as fast. And so people have said, well, that's interesting. If beta acts to kind of suppress the growth, is there any way we could turn it on and make it
Right,
really
make it
suppress
harder.
the growth?
Yeah.
And so that's really what people have been studying is, are there ways that you can actually turn on and make the tumor grow slower? And that's the tumor suppressive effects.
Woo.
All right, Ricky, you still with us?
I'm trying. I'm really trying here. This is not my
Okay, so we're talking about people who
Yeah.
don't express
right.
the traditional hormone receptors. So
Right.
triple negative breast cancer has the absence of these hormone receptors.
Right.
And now we want to look at how a therapy that stimulates a receptor could help triple negative breast cancer. So what's the role of estradiol or estrogen in this? Give us a little bit of the background on this for TNBC.
Sure. Well, this is where it becomes really interesting because people have, again, discovered the estrogen receptor beta. And what they discovered was that in general, when estrogen receptor beta was present, there was the brakes were being put on. So people started thinking about this in the laboratory and they said, well, if that's the case, I wonder how we could really turn the brakes on even further. And so that's what, when people started studying what are called ER beta agonists. So now we're thinking of, here's the receptor, it's the lock. Now we're going to use a key, and by the way, the key is still estrogen. But in this case, when the key goes into the lock, instead of causing the cancer to grow, it can actually cause it to regress.
That's what we want.
So now we have two receptors, alpha and beta. And what we've been studying in the laboratory is to say, let's make it really simple. Let's just remove alpha out of the equation completely. So let's just not even so let's focus on triple negative breast cancer because we know estrogen receptor alpha is gone.
Right.
What we discovered in that situation is when beta is present, these cancer cells really do act differently. They grow slower. And when we added estrogen to those cancer cells that express ER beta, then we were really surprised because now all of a sudden those tumors grew slower. But also what estrogen did in that situation was it actually inhibited the spread of the cancer to other places.
Wow.
So now we have two different scenarios. The most common scenario, of course, is estrogen receptor alpha. That's what we measure most commonly in the clinic today. And then we have this unusual scenario, which is triple negative breast cancer. And so one of the things we sought to do is to say, well, how often do we actually see estrogen receptor beta present in triple negative breast cancer? As it turns out, you all know this, you've heard the numbers, 15% of breast cancers are triple negative. It might be a little bit higher, right? But depending on what part of the world, your ethnicity, your race, but
With Black women, I think the number is 30%. Yeah.
15 to 30, yeah.
we see some variation. But what we do know is that in tumors where the estrogen receptor alpha is truly gone, it's not there, estrogen receptor beta is present about 15% of the time. And so what we have found is that in that situation, the tumors tend to look and act less aggressively. When you say, well, what does that mean? Well, they tend to be smaller tumors. They tend not to be involve lymph nodes, and they also tend to have lower rates of proliferation. And in the laboratory, what we can do is actually by treating those cells with estrogen, we can actually cause them to additionally grow slower.
Wow.
Now,
Can I ask a question
sure.
here?
Mhm.
And I guess my question is why then don't we routinely stain triple negative breast cancers or really all breast cancers for ER alpha and beta if we know that those cancers behave a little bit differently?
So that's a really good question, and it's the million-dollar question. So when we think about receptors and we think about stains that we do in the clinic, one of the things that we have to show before we introduce a test is we have to show that there's clinical utility. And you say, well, what does that mean? It means that we have to show that by testing for a receptor, in this case, estrogen receptor beta, that it would affect how I, as a practitioner, or as a physician, would treat my patients. We're not there yet with ER beta. We have to show that not only when it's there that it's important, but we also have to show that I should be treating a patient differently. So, for example, should I change the treatment recommendations for chemotherapy? How well does using estrogen work? So these are still what I would call research questions, very important research questions, I might add, but we're not ready to use them on a regular basis until we can prove once and for all that there is utility for our patients and that they benefit from doing that test.
So just to recap, make sure I understand, for the viewers who are watching, about 15% or so of triple negative breast cancers actually do express or have the hormone receptor ER beta, which is a more or a less aggressive phenotype, so to speak. So that cancer doesn't behave as aggressively as others, might respond to therapies a little bit better, right? That's the setup for this research that you're doing. It's looking at those people. Now, how does your tell us a little more about your study then, and maybe the study design?
Sure. So what we're doing is very simple. We're taking women who have a diagnosis of triple negative breast cancer. Estrogen receptor is alpha is gone. It's not there. HER2, the progesterone receptor, those receptors are negative. And these are patients that have a diagnosis of cancer that spread. Their cancer might be, for example, in their lung, or might be somewhere else in their body, their liver.
So metastatic.
We use the term metastatic. That's exactly right. And for these patients, right now, the standard of care is for them to be treated with chemotherapy, or if their cancer involves, or if their cancer has some immune markers. Many of you are aware that there are drugs that are designed to activate the immune system. Women will be treated with medications designed to activate the immune system along with chemotherapy.
We had a great question in the chat. Someone said, how does this relate to the PD-L1 receptor? So somebody's following along with us and really understanding. I know this is a patient who has, I think, metastatic breast cancer, actually, and she wants to understand a little bit more about that. So we're looking at those tumors and patients who are metastatic. Why metastatic and not early stage?
So very good question. So generally, when we study patients who have a diagnosis of cancer, we're bringing new drugs or new approaches to patients. We start first as a proof of principle in patients who have metastatic disease. It's very rare that we would actually start with somebody, let's say, who had early stage breast cancer, who might be cured with just their standard therapies.
Right.
So what we don't want to do is we don't want to be introducing a therapy and substituting it for treatments that we know work, okay? So what are the treatments that we know work for triple negative breast cancer? Well, we know that chemotherapy works. It doesn't work all the time, but we know that it works in a large number of cases. We know that immunotherapy, this pembrolizumab, is a drug that works. We know that there's other drugs that can work as well. So this clinical trial that we're testing, or that we're doing right now, is designed for those women where the standard treatments are no longer working.
Got it. So you give the treatments that are working a chance first, right? So
Correct. Yeah.
Never less than the standard of care. And this is something that we talk quite a bit about as we educate people about clinical trials. You know, we know that the standard of care isn't working for these people. And so we add standard to something else to augment or supplement that effect, and not you get the placebo or you get this totally new drug that nobody's ever tried before. It doesn't work that way in cancer research, correct?
That's exactly right. And, you know, one of the things that's most exciting that I have seen and developed in cancer research over the last 20 or 30 years is that, you know, the success rate for our drugs that we bring into patients is higher than it was 20 or 30 years ago.
that's
And you
awesome.
say, well, why is that? I think we're becoming much smarter about the groups of patients where those drugs might actually benefit patients. You know, it used to be that we would take a drug like tamoxifen and we would treat everybody, and we would hope that it worked for everybody. We're in an era now where we understand that there's no magic drug that's going to work for everybody. Just like triple negative is unique, now we have to find the unique drugs for triple negative. And those unique drugs that work for triple negative may not and may never work for estrogen receptor positive breast cancer or HER2 positive. And that's the really understanding the fact that these cancer is quite complex. But the good news is people are figuring out the complexity. And if we can figure out okay, this is subtype A, this is subtype B, and now I need to give just the right drug for that type of cancer, that we're going to be much more successful, I think, about bringing drugs that work for our patients. Because at the end of the day, what we want for our patients is we want drugs that shrink tumors, that help them, that also give them better quality of life and prolong their life. Those are the things that our patients want, and reduce suffering from cancer.
Yeah, preserving life and not prolonging death. Tammy, let me rope you into this conversation and ask you a question in terms of your role. Do you enroll patients in the trial? Do you interact with patients, or are you more on the data management side of things? Or tell us a little bit.
I don't interact with any patients, believe it or not. I am more on the data management side and the sample management side. Administrative side of things.
Gotcha.
What does sample management mean, Tammy?
So I do the audits for all of the samples that come in for this study that get read by a pathologist, and then I go through and record them in a database, and then I get them stored.
Which is huge, because the work of the trial begins after the clinician or the doctor explains it to the patient. I mean, there's so much work leading up to it, but once you get a patient to agree to be on a trial, then there's a lot of stuff that happens after that, Ricky, as you well know, and somebody has to execute all this. There's a really intricate system to getting samples, to storing them, to de-identifying the data and taking the names and things out of it so that, this information can be stored and used, and we're not using just patients' names and dates of birth, and then figuring out the different classifications of all these patients too, right? Like you have to collect, I guess, demographic data on these patients.
I don't actually collect the demographic data, but yes, there's data collected on all the patients. Yep.
But you
Awesome.
you can really kind of connect the whole patient. Like you're looking at like that cell or those cancer cells relative to really who this person is, and then how that fits into the big picture of everybody that you're looking at.
Mm-hmm.
All the
And we're responsible for also, making sure we don't lose the samples. We keep track of the samples
right.
for a clinical trial. And then if we wanted to go back and look at them for something else, we would have those slides.
Samples, right? Great.
One of the things that I think about, in a trial like this, and there's many trials that are this way, is that initial screening is so important, because the screening, of course, allows us to say yes or no, this tumor has estrogen receptor beta. But if I think about it, this is where we're going in the field, so that when I see a patient who has breast cancer, metastatic triple negative breast cancer, one of the things that I want to know as much as I can about that tumor, so that I can line up as many possible therapies for that patient as possible.
Mm.
And I use the many people are familiar with the game of chess. Some people like checkers. But in these board games, it's not about just where you move next. It's about thinking about your move two or three moves down the right. You have to kind of outguess your opponent. And that's a little bit like it is in the case of treating patients with cancer, is we want to line up as many possible therapies as we can. And of course, therapies that are hopefully going to work for those patients. And so one of the things that's really happening right now is we're taking information from the tumor, and we're using that information to select the right drug for patients. Estrogen receptor beta is one, but what happens if your tumor is estrogen receptor beta negative? Well, it's our responsibility then. We have to find another target. We have to find another receptor. We have to find another drug combination for that woman, because if the standard treatments are not working, we have to find something. And the good news is that we're becoming much smarter about trying to really find the different subsets. When Dr. Gary talked about heterogeneity, boy, that's a big term, but that's so true. There's a lot of complexity with cancer, but it's our job to really take this big jigsaw puzzle and put it together.
Well, you're hitting on so many things that we're trying to educate on, Dr. Goetz, because I don't think, when you have cancer, you say you have cancer, you're going to die, right? Your mind is already fuzzy. Okay. I mean, kind of when we talk to doctors, it's like, wah, 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 once they say the cancer word, you kind of lose perspective, but we want people to understand that the work that you do is so critical to saving our lives, that you're in the background in the lab doing this work so that patient sitting in the doctor's office with their oncologist can get better. And I think that, we kind of take a lot for granted. When you go to the doctor, you think your doctor knows everything, but what people don't realize is that there's so much science that goes into that little pill they're going to prescribe or that chemo infusion. And so I just want, you're doing such a great thing for us, just to show us what's going on in your world that's going to relate to, the lady that called me today and said, gosh, I have TNBC stage 3C. What do I do? And so thank you for all that you're doing. But I just want people to see that this work is so important, and that if someone can contribute to your work by giving you a piece of their boob, they should do for all of us.
Wow, I love it.
Well,
coming out. It's coming out anyway, right, Ricky?
I know, but
I do think you're right though, and I think people need to see their doctors as researchers as well, and know that it's not just a handle in the doorknob and they're out the door, but like this is an entire segment of someone's career outside of just seeing patients, not just seeing patients, but seeing patients and teaching and doing research. All of these things go into, are baked in the cake of a career of a medical oncologist like Dr. Goetz. And it makes for a really great conversation, because in the chat, somebody said he is so easy to understand, right? Like we get it. We understand what you're saying because you're taking the time to explain it. And, as we know, the number one reason Black women aren't enrolled in clinical trials isn't because they decline, it's because they aren't asked, right? Nobody sits down and spends the time to screen and to do that initial screening. And on that question, we did have a question from the chat that said screenings are down, and how would that delay have an impact on treatment outcomes, even on the trials themselves? So how has COVID impacted your trials?
Well, that's a really important question. When we hit the height of COVID, all of our clinical trials shut down. You can imagine our goals at that point were just all of us to make sure that we treated, and by the way, one of the things we had to come up with, and I'm sure Dr. Gary was at your center as well, we had to make sure that the ventilators were there for the patients in the ICU. And so some of those ventilators that would have otherwise been used to put a patient under for a breast cancer surgery were moved to those ICUs. And so that really prompted us to really be thinking about, well, who are those patients that need surgery, or who are those patients need chemotherapy? We started giving, I think, a lot more therapies during COVID prior to surgery, because we knew that operating room might not be available. So we had to treat them with, perhaps it was chemotherapy, perhaps it was tamoxifen, or some other treatment for a period of time until they could get surgery. Then, of course, there's those clinical trials, perhaps in patients who had metastatic disease. Obviously, for a clinical trial, we're testing sometimes new drugs. And when we're testing new drugs, we need patients to come back and forth just to see, hey, how are you doing? How are you tolerating that drug? Is the tumor shrinking or not? But you can imagine that was hard for a patient to come in from across town into a center, because you're exposing yourself to COVID, right?
Right.
And so it's certainly that affected our clinical trial. I mean, thank goodness things are better right now. And so we all of us across the country weathered this.
That's great. I think also, one of the things that we hear so often from patients about trials is, I'm going to get the sugar pill and die. And so I think what you're showing here is there is no sugar pill in cancer research, that you're all about protecting the patient and doing what's best for them and finding a solution that might not be there. And you said it a few minutes ago that, you know, you're all over them trying to figure this out. And I think that's what we want people to hear, that you're going to get care from a Dr. Goetz when you're in these trials, and you're going to get this kind of attention, and they're going to be looking to find your solution, which could be different from somebody else because it works in your body. You know what I mean? And not somebody else's.
And Ricky, I just wanted to follow up on that. You know, I think that, you know, when you think about the word clinical trial or research, it does bring in a lot of questions, I think, for patients. And I think we need to acknowledge that. For what we do in the care of patients with cancer and for our clinical trials, one of the things we have to make sure, and all of us, Dr. Gary, myself, is that patients are getting the standard of care no matter what.
Say that again and explain.
That our patients get what I call the standard of care, no matter what. What is the standard of care? Well, you know, for a patient who is newly diagnosed with breast cancer and just has a lump in her breast and it's triple negative, the standard of care is to get chemotherapy and to follow that by surgery and maybe some radiation therapy as well. So we've learned over the years what works. And so we have to make sure that patients get those therapies that work no matter what. But our focus is really on those patients where they get the standard.
It didn't work.
And it didn't work. And that's where our research, if you will, we don't need to improve the outcomes of women who are cured. That's not. In fact, what we need to do is to really focus and say, listen, a lot of our patients right now, by the way, are cured with some of these standard therapies, and it's a good thing.
Right.
But we still have a long ways to go. And I tell my patients, gee, I'm going to always offer you a clinical trial until I can look you in the eye and say I've got a 100% cure rate. And so in patients, obviously, where cancer has spread, it's metastatic, we want to make sure that you're getting at least the known therapies that work. But what about those women where they've run out of options?
Mm-hmm.
Or perhaps a patient who maybe the standard of care would be normally what we would use, but she can't tolerate that standard. Maybe she has a side effect to
Right.
a particular drug. And then what do you do?
Right.
Well, that's where research is very important, because we want to be able to offer that woman a drug that is going to be safe, it's going to be effective, and it has the option to improve the cure rate. And ultimately, as Dr. Gary said, you know, not prolong the death rate. I can't remember how you said that, but it was actually very good.
Preserves life and doesn't prolong death. Now, can a therapy change the hormone receptor expression, right? Like, aren't these cancer cells tricky and it learn how to evade therapies?
Great question. So, you know, I don't know that our therapies necessarily change the receptors, but one of the things that we do know that can happen is that there can be heterogeneity. And let me just think about it this way. Let's say you have a salt shaker, and it's all salt, but you put in, you know, a few flecks of pepper in there. That pepper in there is the heterogeneity. And perhaps sometimes we can have a drug that gets rid of all the salt, and perhaps we start out and 99% of it's salt and 1% is pepper. What happens if we get rid of all the salt?
Right.
Get rid of the 99%, and all of a sudden it's the 1% pepper that's left, and that starts growing. And that's heterogeneity. And that's one of the things that we struggle with cancers, because sometimes we have drugs that get rid of 99% of the cells, but we're left with that one rogue cell that then sort of becomes a problem and starts sort of taking over. And so that's one of the things that we think about with receptors. And sometimes it's the black, or in this case, a white, that can potentially be the one that sort of begins to change, and is not necessarily change, begins to grow. And so that's the heterogeneity. So I like to think of it this way, is that if you had a drug and it worked in 99%, but 1% didn't, then all of a sudden you got to focus on that 1%. So that's heterogeneity.
Wow. So really quickly then, how's the trial going? How many patients have you enrolled, and what do you hope to find?
So thanks, Dr. Gary. You know, the trial is actually going especially this year, it's been going much better. We opened this trial right in the midst of COVID. So trying to get a trial activated in the midst of COVID was difficult. The exciting thing is now we've activated this trial across the United States. It's open, for example, in the Northeast in Georgetown. It's open in New York City at Montefiore. It's open, for example, in University of Alabama, in Mayo Clinic in Jacksonville, out at the University of Washington in Seattle. So it's open across, and by the way, University of Chicago as well. So it's open across really the country. What we're doing right now is we're doing a lot of screening. We're having patients who are, they're have a diagnosis of triple negative breast cancer. The cancer is spread, and one of the very simple things we're doing right now is asking their patients, if they're interested, is to send in one of their specimens to our group, and then we look for the expression of that, or the presence of that estrogen receptor beta. If it is there, then that provides an option for that patient potentially. If it's not there, that's important for the patient to also know, because then they need to be looking for other ways to treat that cancer. So we're doing a lot of screening right now. We have registered patients under the trial. One of the very first patients that we treated here at Mayo had a remarkable response to estrogen. And so it was just, seeing that patient and seeing the response. And so, but we're still in the throes of studying it, and we'll know when the study is done, did estradiol do what we think it's supposed to do? And we want to get that answer out for patients. And by the way, if it does, one of the things that's really exciting is there's another generation of drugs that are called estrogen receptor beta agonists. Well, they're just like estrogen, but perhaps we may not get some of the side effects of estrogen. So that's one of the things that we're also excited about is, okay, if this first part of the trial is positive, maybe we can develop better drugs as we go along as well.
That's great. So you're saving lives. So these people are doing better.
We hope.
Well,
Absolutely.
We're gonna know about that when we get the final results of the trial. But as I said before, one of the things that's so gratifying is when you see patients, they run out of options, or maybe they don't have options that they like, that have side effects,
Right.
and you're able to introduce a treatment that makes a difference. I can't tell you how gratifying that is. It's what makes me get up in the morning.
Yeah.
I also know that what haunts me is when I give a therapy to a patient and she doesn't respond. That tells me we still have a lot more work to do.
Is 6 months at the time frame for which you'd expect to see a response, or not?
The great question. When a woman is first diagnosed with metastatic triple negative breast cancer, I always tell patients when we start a new drug, there's two groups of patients, right? There's patients that respond, and then there's patients that don't respond. And our goal in this study is to really make sure that we're going to call it success if at least 30% of patients are in that group of women that are responding. Now, unfortunately for triple negative breast cancer, and many of the women know this, is that some of the standard therapies, they initially work well, but then they stop working. And so our goal is to provide additional options, additional medications that potentially would work for these patients.
So for the person who's watching, who's thinking, okay, I've got TNBC, maybe I should be taking estrogen. How do we help them understand the difference in what we're saying here when we have understood estrogen supplementation to be an independent risk factor for breast cancer?
That's a really good question. And as it turns out, the data with estrogen in breast cancer are complex.
Yeah.
You say, well, why is that? Well, in general, of course, if you have breast cancer and it's estrogen receptor alpha positive, our goal is to actually use a medication that blocks estrogen. If you look at a patient that has never been diagnosed with cancer, and perhaps she's at risk for developing cancer, we did these trials years ago where women were actually given either estrogen or estrogen plus progesterone. Now, I'm introducing a brand new drug here, but progesterone is another drug that was given commonly, and the name of this was called Prempro. As it turns out, the studies with estrogen and estrogen plus progesterone actually were not what we thought. What those studies showed is that if you combine estrogen plus progesterone, it was bad. It was bad all the time. It led to, excuse me, higher rates of breast cancer, but it also led to other problems as well. And so there was this notion for a while in the 1970s and 80s, of course, that it was the estrogen was the fountain of life, and you just give it and everything would be great. And as it turns out, estrogen plus progesterone was not that. Now, in the trials testing estrogen alone, actually, as it turns out, estrogen alone did not increase the risk of developing breast cancer. Now, that was actually also an interesting finding. Dr. Gary, you're right, though, completely about when we think of estrogen supplements, most people most commonly are taking estrogen plus progesterone. It didn't work, and you should not be taking that, at least in a prolonged period of time. So going back all the way to this question of estrogen, as it turns out, it's a little bit more complex, because estrogen alone, without the progesterone, actually did not increase the risk of developing breast cancer. That being said, we're not giving it in general to patients, because we're still not convinced, we have to have scientific evidence that giving estrogen for a prolonged period of time is of help to patients. Now, there are some situations where women take estrogen for a short period of time, and I think that around menopause that there certainly is reasons to do that, but taking it for a prolonged period of time therapeutically, there's just no data for that. And so what we're doing here is saying, is there a small group of patients where actually taking estrogen may be helpful for the ER beta positive? And again, we'll see how those studies show, what the study shows.
Wow. Wow.
May I invite you to consider, if you don't already, as one of the endpoints or a data point to collect information about the sexual function of these patients and whether or not their sexual satisfaction or function has improved, because quality of life is a really important issue for these patients. And so if they're going to be taking estrogen supplementation, does it improve anything for them? And I think it's an aside, and it's not a life-saving question, but it is a question that needs and deserves an answer.
And you bring up a point which is really important, and that is one of the things that we're doing a lot more, and I think we're doing a better job than we did even 10 years ago, and that's asking questions about patients. How are you doing? How are you doing on and we call this PROs, which stands for patient reported outcomes. By the way, we used to ask patients funny questions that we didn't really get at the heart of this, and now we actually simply ask patients to tell us how they're doing, and we have questions that are actually do really get at some of these things like sexual function or hot flashes or nausea. How did this drug actually really make you feel? So that's really important as well, because as we develop these drugs, we have to be thinking about quality of life, and we want the drugs that work the best, that have the best quality of life. That's the ultimate.
Wow, I know, it's funny that you have to think about today, how are you doing? And I think we should have so many patients tell us, my doctor doesn't really care. So how can we help you? How can we reach you? How can people reach out to you? Like, what should we do now to help you get more science?
What should they ask their doctors about? Someone in the chat said, what should I ask for people who are interested, how do they ask their health provider about this?
Well, I'm going to just step back and just say, first of all, thank you for the opportunity to be on here. And I just also want to applaud all the women right now who are going through what is a really hard time. This is not easy. And this really extends more than just ER beta, but it is the importance of to be empowered to understand about your diagnosis. And knowledge does empower you. It allows you then to really then say, okay, based on this information, I need to do this. And I think one of the real take-home points I want to make is that triple negative breast cancer is a bad disease. We know that. But we do know that patients can be cured with triple negative breast cancer. And for the ones that are not, we need to do a better job. And our job is to really to bring new drugs to you that are going to make you live longer and better. And we want you to know that that's what we're here for. When it comes to ER beta, this is just, I think, one of really many different approaches to study triple negative breast cancer. And there will be another drug and another trial following this one for many patients at their center. And I was talking to a researcher not too long ago. He was at the Oregon Health Science University, and he was describing what they do, and we do something similar, whereas we take patients who have a diagnosis of triple negative breast cancer, and we try to identify all the drugs and all the biomarkers. By the way, biomarker is a big word, but it's one of these receptors, so that we have as many options for patients. So a patient walks in the door and she has cancer that has spread. We try to find as many targets and provide as many options as possible. And ultimately, that's what we have to do for our patients.
Wow.
That's incredible.
So can people, how should they want to join the trial? Or you put that in the chat, Moha, how to join?
Well, I put the link for the study sites and the clinicaltrials.gov link. If you're interested in seeing about your eligibility, you would need to contact the actual study site. And I think we can probably put the link for that as well. Tammy, if you put that in the chat, we can put it into the Facebook group as well, so that people could reach out and talk to their doctors and get some more patient-friendly information, because clinicaltrials.gov is a little heavy.
Help blindfolded. I hate
But,
that.
but if there's some patient-friendly information about the trial, or even physician-friendly information that sums it up, we can put that link and people can take that to their providers.
Yeah. And we'll post it on our Facebook page and in our social. And as usual, you guys can always just email me at ricky@touchbbca.org, and I'll hook you up with Tammy and Dr. Goetz and get you whatever information you need. But thank you so much. And you have to come back again.
Yeah.
Well, thank you. It was a pleasure. And again, look forward to the opportunity in the future to come back.
Yeah. And you're so caring and loving, and so not like so many doctors, like Mo helped me define what I see, what I believe health equity to be. And health equity to me is when the doctor treats you like their family. And I can see that you do that. So I so appreciate that, because so many doctors don't. They rush out of the office. And we know that from our research that women walk away from trial conversations that they started with their doctors still not feeling informed. And so thank you for the time that you spend, and we'll do more of this. We'll do more of this, and we'll write an article about this to put on the Black Doctor website.
That'd be great.
So, yeah, we're gonna work on that. We'll show it to you, Dr. Goetz. And just one more thing, you guys, we are doing, talking TNBC this week. So we're actually gonna do a session on Friday with our two of our other favorite doctors, Lori Wilson and Tiffany Trena. We love them. So I put that information in the comments as well. Sign up to come to our webinar. I'm going to be interviewing them. And, we got to keep talking about TNBC, because we got to get rid of it. Belle is waiting. I'll tell you a quick story. So Belle, my 4.5-year-old granddaughter, asked me last week, so Debbie, she calls me Debbie, why don't you have those things on your boobs that baby heart sucks on? Because her mom is nursing her baby sister. So we had our first genuine conversation about breast cancer. At 4.5, she wants to know why my boobs look different, right? So we can't start talking about this early enough. And I hope to God that TNBC is gone by the time she gets boobs in 10 years. So you got to help me with that, Dr. Goetz.
Absolutely. So if you've been watching, we've been talking about TNBC, we've been talking about emerging therapies, research, clinical trials, health literacy, the relationship between doctors and their patients, and how this could all be different. And because it could all be different, and it someday will be. So we want to thank Dr. Goetz and Tammy Greenwood from the Mayo Clinic for coming and discussing their research today. And we hope this has been relatable and reliable and real information for you. It's what we set out to do every Wednesday night here on blackdoctor.org at 6 p.m. Eastern. The doctor's in.
Doctor's in. And it's all about love.
Absolutely.
Thank you. Resty love.
There it is.
Rusty love. You
Rusty
gotta do a
love.
Rusty love sign.
Dr. Goetz, you got to do the heart.
Make her heart. You gotta make her heart.
I
Rusty
probably
love.
didn't do it very well, but
You're good. Rusty love. Thanks for all
There it
your work,
is.
all you do. Thank you so much. Be
Take
blessed.
good care, everyone. Good night.
Good night.